the feeling a lot of nurses are getting nowadays is that that's exactly what the assessment is for. It's to make sure we get the information from OASIS so that we can get paid, and my assessment is secondary to that. What we have is that studies have shown the farther away you get from the actual assessment, the less you remember. So if you see a patient at 8 a.m., by the time you're getting to your documentation, which could be 4 or 5 or 6 or 7, depending on what else is going on in your day, you probably remember about 20% of that interaction.
Hi everyone, welcome to the podcast. I'm Gaurav Henry, and today we are talking about something that is top of the mind for almost every home health leader right now: the future of home health EMR. Over the last few years, EMRs have become central to how care is delivered, measured, reimbursed, and audited. Yet at the same time, we keep hearing the same frustrations from nurses, clinicians, and operators. Too much documentation, too many clicks, systems built for compliance first and care second. At the recent NAC conference, our guest today delivered a session that really stood out because it cut through the noise and reframed the conversation. Instead of asking what technology can do, she asked a much more important question: how do nurses actually think, assess, and make decisions in the home, and why our EMRs are not designed around that reality? I'm joined today by Kathy Duckett. Cathy is a nationally recognized leader in home health and hospice operations, clinical practice, and healthcare technology strategy. She has spent decades working at intersection of nursing regulation and innovation, advising providers, vendors, and industry organizations on how to use technologies in ways that genuinely improve care delivery. At NAC, Cathy spoke on the topic Next Gen Home Health EMR, Nursing Expertise plus AI. Her message was very clear. The next generation of EMRs will not be defined by more features or more data, but how well they support nursing judgment, reduce unnecessary burden, and use AI responsibly as an assistant rather than a replacement. Today, we are going to unpack that message in a practical way. What is broken in today's EMR? What a nurse-centered EMR actually looks like? Where AI can truly help and where it becomes risky, and what leaders should be doing right now as they think about EMR modernization. Cathy, thank you so much for joining me. It is great to have you. And I want to start by grounding this conversation in what you shared at NAC, because it challenged a lot of assumptions people have about EMRs and AI in home health. Cathy, can we start with some of the questions?
Sure, absolutely. Thank you for interviewing me today.
My pleasure. It's at NAC, you frame the future of home health EMRs as fundamentally a nursing problem, not a technology problem. What is the core disconnect between how EMRs are designed today and how nurses actually assess and reason about patients in the home?
There are several disconnects. One of the first one is the way we do initial assessments, that we have the OASIS that we have to complete for the federal government, for Medicare, well, not for everyone, every adult. Mm-hmm. And it's very specific, it dictates to us the way in which we need to ask the questions. So exactly. So that means that there can be no reframing of the question to make it easier potentially for a nurse to understand. The other thing that happens, though, is that CMS has said that is not a complete assessment, so that the nurse is expected to add additional information to make the assessment holistic and do a complete assessment, a psychosocial, a functional, social determinants of health, physical, mental, all of that needs to come together. When nurses are taught how to do assessments, we're taught how to assess the patient holistically, and we're not really taught, and using branch logic. So we're not really taught that we have to go question by question by question by question by question. But what we're taught to do is to do the initial assessment, and then based on the patient's finding, that branches out into additional questioning in that area. And it's very organic. And based on that assessment, then you assess the medications, then you do the interventions. The way that technology has been designed, the way the EMR has been designed really is segmented so completely that it's huge. So it's very easy for the nurse to answer one way in the beginning and then answer another way later on. Typical example of that is that in order to have the patient be eligible for Medicare services at home, they have to be homebound. And there's very specific criteria in terms of what makes a patient homebound. So logically, you would think that the very first thing you have to determine is whether the patient is homebound or not. But the homebound status is really based on the nurse's assessment of the patient's physical and mental condition, right? And the barriers in their home that prevent them from leaving their home easily. By asking the question up front, which most EMRs do, the nurse is expected to make that judgment before she's had a chance to assess the patient.
Right.
The logic makes sense because if the patient's not homebound, don't spend 2 more hours in the home. The problem is that the homebound status that I pick when I first walk in may be different once I completed the entire assessment. So what we need EMRs to do, if we have to say upfront basically why the patient is homebound, the EMR really needs us to be allowed to do the rest of the assessment and then come back to that homebound status because there may be a more compelling reason why the patient is homebound than was first obvious to us. That's just one example how we've set the EMR up to answer the questions and predominantly to answer the questions that the OASIS needs us to answer. And the feeling a lot of nurses are getting nowadays is that that's exactly what the assessment is for. It's to make sure we get the information from OASIS so that we can get paid. And my assessment is secondary to that.
So that I have a follow-up question. So, my second question would be around documentation burden and its real cost. So you highlighted that nurses spend an extraordinary amount of time on documentation. Much of it is redundant. Beyond burnout, what is the hidden clinical or patient safety cost of this documentation overload that leaders often underestimate?
Again, I think that there's several. We expect that the nurse is going to spend approximately 2 hours in the home doing the assessment, doing the interventions with the patient, and completing your documentation. The reality is, because the documentation for an OASIS is so complex, that the nurse is going to spend an additional 1 to 2, potentially 2, but definitely 1 hour later on completing the assessment. The challenge we have is that studies have shown the farther away you get from the actual assessment, the less you remember. So if you see a patient at 8 a.m., by the time you're getting to your documentation, which could be 4 or 5 or 6 or 7, depending on what else is going on in your day, you probably remember about 20% of that interaction. So now the nurses are going back hours and hours and hours and hours later to try and finish it, which means the information is degraded based on their ability to remember how to answer the rest of the questions. That impacts the patient in terms of potentially not getting a true picture of what the patient's clinical issues are, which affects the way you write the plan of care and the care plan, and potentially, because of PDGM, could affect your reimbursement as well. And I think that all of that comes together it frustrates the nurses, because now they're spending more time afterwards. They want to be done. You want to see the patient, do the note, take care of it in the patient's home, be done, move on to the next patient, and physically be done and mentally feel like, okay, I've got this set for this patient, and then move on. Because that patient, depending on how many admissions you have, you might have 3 admissions in the day. That's a lot. You might have 1 admission and 4 more patients. That's 5 patients you're seeing. So and they're all different. So we have to make sure that we get the information we need, especially up front. Moving forward, what happens is that you can have disconnected visits because you're not getting the relevant information that you need in a timely manner to see the patient, to make sure that you know what needs to happen with the patient going forward. In addition to that, we get referrals. Sometimes our referrals are 30 pages. The hospitals just send us everything. Right?
Yeah, I've seen one of those. Yeah.
Because they don't want to miss anything. The problem is I don't have time to go through 30 pages of documentation to pull the nuggets out for what's important to me.
Right.
EMRs could definitely extract. That's what AI does all the time, right? It extracts that information, that I mean, we love it. That's what it does.
And that's some of it, what we're doing at Corporate AI, is like, extracting that information so that we can give the information which is relevant for the nurses, and, they can make a decision based on
Right. So pull out the
just.
nuggets that I need, give them to
Mhm.
me in a very concise way so I can quickly scan what's going on, what the hospital thinks is really going on with the patient. Then I can go in
Right.
and do my assessment. Sometimes it's right, sometimes it's not right, but at least
Mhm.
I've pulled out what I need to know. And then
Right.
now if I miss something, it was on page 27, not helpful to nurses.
Right. Right. Thank you so much for that. Yeah, very well explained. So, compliance driven design versus clinical thinking, the point that you touched upon in question number one, right? Because you said that mostly, the home health EMRs are built around CMS and OSS requirements. So, how does designing around compliance first distort the clinical story of the patient, and what gets lost in that process?
Compliance is really important, and I don't want to underestimate or not make people think that it's not important, because it absolutely is important. We want to make sure that that we're in compliance with the federal laws and regulations. We want to make
Right.
sure that we're doing the complete assessment that we need to do. I think the problem is when you focus on that, you lose sight of the patient holistically. I think
Hmm.
that because compliance can be so black and white, you
Right.
miss the nuances that come into developing the plan of care for the patient that actually would make the care that you're giving better holistically for the patient, and more in the concept of what CMS said, which is helping the patient reach their own potentials in terms of the skilled interventions that the nurse does. So if I'm just being compliant, did I answer A, B, C, D, E, F, and G, but I'm not using that critical thinking that is so
Mm.
important for nurses and what nurses are really educated to do, then I'm filling out the paperwork, but I'm not necessarily taking care of the patient. And you have to do both.
Yes. Okay. So, my follow-up question would be about, the dynamic versus static patient records, which you mentioned in your speech as well. You spoke about the need for dynamic documentation that evolves with the patient rather than the static forms that get filled and forgotten. What would a truly dynamic home health record look like in day-to-day nurse workflow?
It would update the information in real time. It would, as I'm completing the nursing assessment, rather on the initial assessment or ongoing assessments, it would be helping me to make sure that I haven't missed something. It would be updating my care plan as my interventions are updated. So we have the plan of care, which is the document the physician signs, but then we also have the care plan, which CMS has now said must be a dynamic document. And the challenge we have now is it's a static document. So the nurse has to do all of her informations. Then she has to go back to the plan of care and then update the plan of care as the interventions are done. The goal and the intervention goal is met, and then the ultimate goal is met. What should happen is that as I'm doing my note, as I'm being prompted for interventions that I need to do in order to complete the care plan, once those interventions are done and I've documented the patient understands no further interventions are needed, the care plan should dynamically update so that by the time I get to ready to discharge the patient, the majority of the care plan should either be completed or there should be documentation within the care plan that says why I was unable to complete that specific intervention that I thought 4 weeks ago that I was going to be able to do. Then when I come to do my discharge summary, the care plan has been dynamically updated. I've been prompted to make sure that I've met all my interventions, and then I can discharge the patient appropriately. The other piece of that is what should happen is that prior to walking into a nursing visit, I should be able to get a very short paragraph that says to me, this is what happened on the last visit. This is what the plan was for what's going to happen on this visit. Because I may not have been the nurse that saw the patient before. We have a lot of patients. We've gotten to the point where it's very difficult for the same nurse to do every single visit. So what that
Oh.
means is our coordination of care has to be better. Because if
Mhm.
I'm not going to be doing every visit for you, then now I'm part of a team of nurses that's caring for you. So the coordination of the care is important, becomes even more important. In the hospital, at the change of every shift, we do rounds. We give reports so that the next shift knows what needs to happen. In home care, we don't have the opportunity to do that. The expectation is the nurse that's going to be seeing the patient is expected to read the previous note, which may have been 2 or 3 days ago, and then look through the EMR to see what has happened in those 2 or 3 days and how that's going to impact the patient on my visit. It would be much better, and AI can do this, to have all that information dynamically retrieved so that just before I walk into the visit, I can, not just before, but before I walk into the visit, I can be now up to date with what was happening to the patient from the last nursing visit to the following nursing visit, including any labs that were drawn, including any doctor visits that were done, including any other interventions that happened from other therapists or social workers or something in the home health agency. All that information is easily retrievable with AI and should be given to me so that when I walk in, I have a clear picture of what the intent was, and then what's happened with the patient now, so that I can develop what I'm going to do as I walk in the patient before I assess the patient. Now, of course, once I assess the patient, the plan may go, out the window because of something that's going on immediately, but at least I have that information. I'm better prepared.
Of course, yeah, with AI, I think, that dynamic retrieval of data can be made much easier. But, let's not focus on the technology. You mentioned about the meaningful involvement of nurses, right? Building this technology, right? Because it's not focused around how nurses kind of go about their business day to day, right? In their workflow. So my next question is, around that. Many vendors claim that they involve nurses in product design. From your experience, what does meaningful nurse involvement actually look like across design, testing, and governance? And where do vendors usually fall short when designing an EMR?
What we found with studies for that other people have done is that nurses tend to be have late involvement. So, and especially true in home care. Generally in home care, the nurses are not involved in the design or the development of the product at all, even though home care nurses are going to be utilizing the product. So even if you have EMR systems and you have a nurse on your team, your design team, her background may not be home care. And if you're designing a home care EMR, then your thinking is that every nurse is like every other nurse, which is just like saying every single person with a degree in computer science is just like every other person with a degree in computer science, right? So, well, you have a degree, so you can do design, and you have a degree, so you can do coding, and thinking that specialty doesn't make a difference. And with nurses, people tend to think that. People tend to think that if you're a nurse, you're a nurse, you're a nurse, and you're working in this area of nursing, and so you could easily adapt to that area of nursing. Nurses will tell you that's not true, that we all have specialties. And even though we can move between specialties, we still have to be trained in that specialty. I could not walk into an ICU today and take care of patients. It would be impossible for me to do that because I don't have the knowledge of what goes on in the ICU, the general protocols. I'd have to be updated on the equipment. There's a lot going on that I would need to know. And I think it's like saying you're a lawyer. You can do family law today and you can do corporate law tomorrow. What's the problem? You got a law degree. So if you're thinking about developing a product for the end user, and the end user is the field nurse, then you need to involve people who really understand what that means. And many times nowadays,
no-brainer, isn't it? That should come naturally to the product design companies or product development companies, that involve as many nurses as you can from different fields, so that you can you can cater to them better instead of not having any at all and just going by deductions or logic to make it, when the ground reality can be completely different.
Right. And I will tell another thing is that I started off by carrying a bag, by being a field nurse. And then I was a field nurse, and then I was a clinical manager. I was a director. I've been a chief clinical officer. I've designed specialty programs for nurses, wound care programs, telemedicine programs. So I have started my career in the field, and then spent my career with interacting with nurses that are still in the field. Another challenge we have is that EMR companies go straight to the bosses. They go straight to the CEO. They go to the director, the clinical director of nurses. Now, they don't say, what's your background? They don't say to the director of nurses, how long did you do field home health before you became a director? Because what's happening nowadays is that there are frequently people in clinical management positions and directors of nurses who have never ever worked in the field of home care. They came in as managers. They've been a
Right.
director in another field, so they came in as a director. And they may be a very good director because their management skills are very, very good. But now you're asking them to help you design the tool for for the nurse in the field. So those directors should say, management is my specialty. Field nursing is not, because I've never done it. Let me bring in my field staff and have you meet with my field staff, because they're the ones that are going to use the tool. If you have clinical directors, if you have CEOs who are saying that,
Right.
fantastic. That's what they need to do. And then they need to say,
That's
you're
amazing.
designing a scheduling aspect of it. Let's bring the schedulers in and see what it really means to try and do all that if they don't understand that piece of it. I think that becomes key too. So it's not just home care, but it's also making sure you have the right people at the right time for what you're trying to do.
Right. So, yeah, I mean, I wanted to ask you that question, and you answered one of my questions is like, what leaders should demand from EMR vendors actually? Like, so necessarily, I think what you said was like the CEOs and director of nursing should actually get all the nurses involved in trying out the EMR before they sign up, because mostly the deals are done between the CEO and the vendors, right? It's not like a decision making process does not involve nurses around, and the CEOs or the DNs just visually see it, do a demo, use it for some time, and then adopt that system, and then they are and the nurses are expected to adopt all their workflows around the EMR, not the other way around,
Right.
right?
And I think then what happens is that the nurses have a hard time learning and adapting, and they're spending even more time. So the productivity is decreased. And now the CEO is not happy about that. And they're feeling like this was a bad decision. So now
Yeah.
you begin to have a conflict between the EMR, whose salespeople said, "Oh, this will be really easy. You won't have any problem. It'll be perfect." And then the reality is it isn't.
Whether
And
it
now
is.
the CFO is saying our productivity is down because the nurses are still having to learn how to adapt to this new system. I think that
Mm.
those are the hidden costs that occur. And I think that you could prevent that by, before you brought it in, if you have a choice, if you're part of a huge healthcare system, as the home health agency, you may be told, this is the system. This home health module is what you're going to do because this is the system the healthcare system has bought. That's a totally different thing. Although I did work for a large healthcare system, and we had a
Mhm.
telemedicine program, and the EMR came in, and the EMR didn't do what we needed it to do in terms of the integration with the telemedicine program. And the EMR group said, okay, we're going to send a special team so that we make sure that we develop what you need, because we said we're not going to go backwards because our old
Right.
system, we were doing this and this and this. So they very intelligently said, let's bring out a computer science team, a group engineers, come out and
Right.
and then work with you to develop the interface between the telemedicine program and your EMR, so we give you what you need. And
I
then
mean,
it
that's
was
how it should
successful.
be.
Yeah, it always should be that way. And it was very, very successful. We were very involved. And from day one, we had what we needed, and our program was able to move forward. And they were able actually to build even more to interface with the hospital and the physician practice EMR. So it worked out really, really, really well. But they did it the way you should do it, which is to involve us.
That's amazing, Kathy. So it was amazing talking about and getting insights from you. Thank you so much for being here with me, and I hope to speak to you pretty soon again.
All right. Thanks so much. It was great
Right.
speaking to you too. Bye bye.
All right. Take care. Bye bye.